These are the case-based learning series that we usually run monthly, and we run them in partnership with Seed Global Health and different universities, Makerere, Bara, KIU, UCU, Gulu, Lira. All universities in Uganda and outside Uganda are welcome. The goal of these sessions is usually to give us a scenario or give an ideal case that would be managed in an emergency department, and how would you follow through care of this patient if you were in the emergency department. These cases are real. They've been managed by the people that are presenting together with their mentors. They give us a snip of what they did, and we get to walk with the journey with them and see what could we have done better. So we do have experts that will be joining us today, and our presenter for today is a fourth-year medical student from Gulu University, Abasa. The other name is very hard for me. He'll introduce himself. And then we have Arinite Godwin, who will be our pre-hospital presenter for this case. And our expert is Dr. Kenneth Bagonza, who is an emergency physician. I'll give him a minute to introduce himself. And then not shown on this flyer is Dr. Oriba Daniel, who is an internal medicine physician and a nephrologist based in Nacho Hospital, supporting training at Gulu University. He will be managing our chat because he was directly involved in care and mentoring our case presenter. So you're all welcome. I'll give each of our presenters a minute, not even a minute, 0.5 seconds to introduce themselves. So starting with the case presenter, Abasa, kindly unmute and introduce yourself.
Yeah, thank you so much. Today's moderator, Dr. Anne. Good evening to you all, the doctors here and colleagues. My name is Nchiri Abasa, a fourth-year medical student at Gulu University, and I will be today's case presenter. I wish we learn from this. Thank you all.
Thank you, Abasa. Godwin?
Thank you so much, Dr. Anne. May I take this opportunity to welcome everyone, and hope everything will be good and you enjoy the session. I'm Arinito Godwin, the pre-hospital personnel for this case. Thank you.
Dr. Bagonza?
Good evening, colleagues. I hope you all fine. Thank you for tuning into today's CPC session. My name is Kenneth Bagonza. I am a consultant emergency physician, and I'll be the expert, I guess, for today's session. I do teach part-time at Bara University of Science and Tech, and but my full-time job is running an emergency department. Thank you.
Yeah, thank you, Dr. Kenneth. We are glad to have you here. Dr. Oriba, don't know if he has joined in on call as yet. Okay, I'll give Dr. Oriba to introduce himself a little bit later when possibly has got an opportunity to unmute. So without further ado, we open up the case with our theme this month is he is burning up. So want to know what is this all about? So straight away, we'll open up the case. Godwin, we have an 11-year-old male who presented with loss of consciousness for 22 hours and fever for 4 days. And we are handing over to Godwin to carry us through the pre-hospital preparation and transit of this patient. Over to you, Godwin.
Thank you once again. This is Godwin. Presenting to you an 11-year-old male who lost consciousness for about 22 hours and is having fever for the last 4 days. Been called upon, and these are the materials I'm to use. The transfer details. Next slide, please. Next slide. Okay. With me, I'm carrying on my PPEs. My
Godwin, there is a bit of feedback. Godwin,
yes,
there is
please.
a bit of feedback. Are you using two devices? Do you mind putting a headset on one of them? Because we're getting a bit of feedback.
I don't know if there is any. I'm not using any other material. I don't know if it is echo, but
There is a bit of echo. Okay, carry on.
okay. With me, I'm having my PPEs, my airway adjuncts, carried on my OPA, my non-rebreather mask, that's the LMA, carried on the suction device, oxygen. I have a non-rebreather mask. I have a diagnostic set of tools, that's the stethoscope, the BP machine, thermometer, plus a light pen. With me, I still have IV access devices. Those could be the cannulas, and then the fluids that I would need on scene, and then spine board that will help me to carry on the patient. Next slide. I am Alnito Godwin, an EMT working with Ministry of Health Ambulance Department. I was dispatched to the community to pick up an unconscious 11-year male. The situation with this patient, this 11-year male has been unconscious for the last 22 hours with generalized tonic chronic seizures and a high-grade fever for about 42 degrees Celsius. In the background, his background, he has been previously managed for malaria at a lower facility with no improvement. He has been vomiting and passing on tea-colored urine. In my assessment, I found out that the airway was at risk. This patient has been vomiting and is unconscious. So there was also fast breathing for about 37 beats per minute. The extremities or the peripheries are warm, weak, fast pulse, with a BP of 98, systolic 98 and diastolic 68 millimoles of mercury. I recommend the usage of an NG tube to prevent aspiration, and then continue delivering oxygen. I initiated 10 liters of O2 via a non-rebreather mask. I inserted 2 large bore cannulas and gave D5 for the start. I recommend admission in the ICU, monitor the seizures, urine output, and do also a malaria BS, brain CT scan, and renal function tests. Thank you.
Thank you very much, Godwin. Once again, I would love to tell the audience, feel free to post your questions, your concerns, either about the case or about anything in the chat. We do have Dr. Oriba Daniel in the chat. He will be managing. Shortly before inviting the expert, Dr. Oriba, kindly say hi, unmute and say hi.
Thank you very much, Anne. It is heavily raining in Gulu. I'm very excited to join you all and also ready to learn from our students. And really thank you very much for what you are doing. My name is Dr. Dan Oriba Langoya. I'm a lecturer at Gulu University and also internal medicine physician at Lacho Hospital. I'm very happy to be here. Thank you.
You're welcome, Dr. Dan. We are happy to have you. So over to you, Dr. Kenneth. Given the pre-hospital report that we have received, What are your initial thoughts? Was the preparation adequate? Would you have done something different? What are your thoughts?
Thank you very much, and I hope I'm audible. Stop me if I'm not. So I think from a pre-hospital perspective, I think the preparation for the patient was adequate. And from the description of this particular patient, it seems like this was quite a sick patient. And it's always good that from a pre-hospital perspective that you obtain as much information as you can when the call comes in to go and pick up a patient, because then that helps you with your preparation on this is the type of patient. If this history was provided to me, and I was part of the team that was preparing to go and pick them up, then I would prepare to I'll be prepared to go as far as advanced airway management and potential mechanical ventilation. And sometimes this might require that you have a bit more resources than you would normally have on a regular ambulance dispatch. And for this type of patient, then would most likely need to have a Type C ambulance with both the equipment that should be in a Type C as well as the expertise that should be in a Type C. And I think because we have a patient 11 years old who's been on treatment for malaria, has now developed a reduced level of consciousness that includes convulsions. And I think there was a history of vomiting as well. And part of the assessment findings seemed to point towards features that are synonymous with sepsis. So obviously, when you're going down there, you're anticipating that they have a couple of issues that we'll get into in a bit later, but you know that just the fact that they have an altered level of consciousness, then they most likely have lost the capacity to protect their own airway. So, and if you're approaching them from an emergency care perspective, then you try and make sure that these things that will quickly kill them are taken care of, and then we get into the pathology that is underlying why they're presenting the way they're presenting. Thank you.
Okay, thank you so much, Dr. Kenneth. We now dive into what happened to this patient when they arrived at the emergency department. Abasa, please take us through.
Thank you so much, our moderator. Right away at the emergency department, a primary survey was made, and the airway was surely at risk because this patient was unconscious. There was intercostal muscle relaxations, and the patient was breathing at a higher respiratory rate of 77 cycles per minute, saturating at 94%. However, he was on a non-rebreather mask, delivering oxygen at 10 liters per minute. In the saturation, it was warm. The extremities were warm. The capillary fill was slow, that it could come back at 3 seconds. The BP, systolic 98, diastolic 68 millimeters of mercury. The pulse rate was 182 beats per minute. Right there at the ED, I witnessed a single episode of generalized tonic-clonic convulsions, which lasted for 10 minutes. And we equally did a random blood sugar, and it was slightly reduced, giving us a 3.6 millimoles per liter. From the exposure, she was really burning up with a temperature of 42 degrees Celsius. Yes, 42 degrees Celsius, not Fahrenheit. And there was drooling of saliva, tongue biting, urinary incontinence. These were associated with the convulsions, and he was not pale at all. Dear audience, let's engage in this poll.
So we have a poll running from the primary survey. What are the imminent emergencies? Please answer. end this when we have at least half of the audience. Okay, so we're going to end the poll in the next 5 seconds. Okay, Abasa, please carry on.
All right. Thank you all for participating in the poll. It was amazing. And these were the intimate emergencies we had: the threatened airway, hypoxia, respiratory fatigue with pending respiratory arrest, shock at risk of multiple organ failure, convulsions, and hyperplexia. Thank you all for participating. You really did well, and let's keep it engaging.
So we have a second poll running after the emergency department intervention for this patient. I would like to end this when we have at least 50% attempt. What are the emergent ED intervention for this patient? Remember the problem list that we had and then look at what would this patient need. We have 33% of participants that have responded. Let's keep the answers coming in. Okay, we have 51% representation. I think we'll bring this poll to a close and let Abasa continue. We're going to share these answers, don't worry. We're going to share the answers at the end of the session. So Abasa, please carry on.
Yeah, thank you for the participation in the 2 polls so far. More are coming. From the emergency department, as we've seen from the previous surveys, we inserted an NG tube. For breathing, we continued with 10-liter flow, 10-liter per minute flow of oxygen using a non-rebreather mask. However, the saturation, you can see it is reducing. It has dropped from 94 to now 88. We chose to transfer this patient to ICU for intubation. Saturation, we delivered 1 liter of dextrose 5% using the large bore cannulas recommended by our pre-hospital person. And we gave intravenous phenobarbital 500 milligrams, a loading dose, and an IV 2 grams of ceftriaxone, a broad spectrum antibiotic. And for the exposure, remember our patient was burning 42 degrees Celsius. Here we gave him IV paracetamol 1 gram, and to monitor the rest of the things, including urine, we inserted a Foley catheter of size 12. Let me give you a sample history. From the signs and symptoms, there was loss of consciousness, generalized tonic-clonic seizures for 1 day. There was non-projectile vomiting, high-grade fever, which were constant for the 4 days. There was no allergies, and for the medications, he had just received 3 doses of IV artesunate, paracetamol, and phenytoin. From the past medical history, this 11-year-old male was managed for meningitis 9 months ago. He had reduced hearing for 5 years now, but there was no any other chronic illness, and his immunization was up to date. It was complete. This 11-year-old male last had a meal 36 hours ago before he presented to the tertiary institution where he was referred to. Events that led to the presentation, he was well 4 days prior he was well 4 days prior to admission, being managed for malaria, but there was no improvement. He had 6 episodes of vomiting in a day, in 24 hours, 6 episodes, and he was passing tea-colored urine of reduced volume. There was high-grade fevers, constant, that couldn't be relieved by either tepid sponging or oral paracetamol. A week prior to admission, he developed productive cough and flu, which was managed with over-the-counter drugs from home.
So now to the audience, I would love to ask, is there any additional information you would love to know about this patient, given what you've had so far from pre-hospital right to the primary survey sample history? Is there something you would love to know more about this patient or about the history that you've been given? Feel free to put the questions or the answers in the chat. And as the audience is placing their questions, we'll move on to Dr. Bagonza. Dr. Bagonza, yes, we've moved to this point. What are your thoughts?
Thank you. So this patient has a number of issues just from the initial assessment. There seems to be a problem right from the airway all through to when you expose the patient. So obviously the airway was compromised by, number one, the reduced level of consciousness, and I think the team had done an excellent job inserting a nasogastric tube, because then once you decompress the stomach, then you reduce, you don't eliminate, but you reduce the risk of vomiting and therefore aspiration. But then that being done, that is still an airway that has not been fully managed, because the reduced level of consciousness then means that the patient has no control of the muscles of the upper airway or their tongue. So when those fall back, then the patient is at risk of having a complete obstruction of the airway. So that required intubation, definitely, and mechanical ventilation. But in patients like this, if you can keep their airways patent and then first correct the hemodynamic problems, because a lot of times if you attempt to intubate them and mechanically ventilate them because you change the pressure dynamics within the intrathoracic cavity, then you run risk of causing further hemodynamic decline. So usually if you can manage the airway non-invasively initially and you correct the perfusion issues, because there are also perfusion problems, then once you have optimally corrected the perfusion issues, then you come back to now managing the airways. I noted that that the patient received a liter of 5% dextrose. Now the patient, of course, had hypoglycemia, so obviously we need to correct their blood sugar. And typically, we recommend that you give 25 grams of dextrose. So 25 grams of dextrose can be 50 mils. This is why a regular adult, but then you'd have to do some pediatric calculations. This is an older child, we don't know about their weight. But if it's a standard adult, then you would use 25, you would use 50 mils of 50% or 250 mils of 10% or 100 mils of 25%. So as long as you get 25 grams. Now the challenge with just giving plain 5% dextrose is that you will correct the hypoglycemia, but once that glucose is consumed, then you have free water that then is distributed equally across all the different compartments. So that means over 2/3 of your volume will leave the intravascular space and go into the extravascular space. So it will not correct the hemodynamic instability your patient has. So what you might choose to give here is you give dextrose. That's just purely for correcting the hypoglycemia, and then you use crystalloids for volume correction. And then I noted, and of course, this child fever, reduced level of consciousness, convulsions. The first thing you're thinking is meningitis, but there's also a history of treatment of malaria. So you're also at the back of your mind thinking, might it be cerebral malaria? So, and if meningitis is one of your differentials as you try and work up this patient for meningitis, then if you're giving ceftriaxone, then you need to give meningitic doses of ceftriaxone. So that would have to be about 100 milligrams per kilo of ceftriaxone as the meningitic dose. And then, of course, so we've talked about the hypoperfusion issues. We correct those as well, and correct the hypoglycemia, because sometimes the seizures might be from hypoglycemia. But then you also give an anticonvulsant if after correcting the sugar, the patient continues to have seizures. And of course, then we also need to think about how do we reduce this very high grade fever. So one, giving antipyretics, but two, we also have to sort of actively cool the patient. So this can be via tepid sponging, or it can even be via giving cold crystalloid fluids, but also exposing the patient to make sure that they cool down. Because when the patient has a fever, they're having seizures, they're having hypoperfusion. So already you know that in their brain, it is undergoing very high metabolism, so it has very high requirements from the heart, but you know they're already hypoperfused, and this increases cerebral injury. So if you can reduce the metabolism of the brain by, number one, stopping the seizures, number two, bringing the fever down, then you can sort of reduce the degree of cerebral injury that this patient will have. And I agree with their plan to have transferred the patient to ICU for advanced airway management, which includes intubation and mechanical ventilation, because when you ventilate the patient, the other thing you do in addition to adequately oxygenating them and getting rid of CO2 is that then you give the lungs a break, so that the lungs don't need as much cardiac output from the heart when they're being supported on mechanical ventilation as they would the patient is breathing spontaneously. Yeah.
Okay, thank you so much, Dr. Kenneth. Yes, someone is asking, did they miss the GCS? So what I want to ask Abasa, just a question here that I think we need to clarify for the team. A question came through, why did you insert the NG tube as part of airway management? It's okay if you don't have the answer, you have a mentor.
Thank you so
Can
much.
pass it on.
I think he later got it as our expert explained the falling of the respiratory muscles on the GI, and I think that very person was he or she Octavius. I think he got it to prevent the risk of aspiration. Maybe an expert can throw in more light in there, but to me it was
that's okay. We shall have the question and answer session later on. Thank you. Please carry on with the secondary survey.
Okay, thank you so much, our audience, for interacting. And I think most of the questions asked, some of them are here. In our secondary survey, we did it from head to toe, and for the head and the neck was stiff. However, there was no jaundice or para, lymphadenopathy or distended veins. We equally did a chest exam and it was grossly normal. However, they were bilateral basal crack was had on auscultation. The cardiovascular system and abdominal examinations were normal. The extremities were warm without any injuries, and the skin was equally normal. In the neurological exam, or which we may call the CNS, he had a GCS of 6 out of 15. 6 out of 15 with eye opening 2, verbal 1, and motor 3. There was generalized hypotonia, that's reduced muscle tone, reduced deep tendon reflexes, but the muscle bulk was normal. That was our secondary survey.
So we have our third poll coming in. Kindly request let it run very fast. What are your differential diagnoses for this patient, given what we've had so far? Primary survey, sample history, and then the secondary survey coming in. What are your differentials at this point? We have 120 people on this call. Let's keep this running very fast so we can close it up a bit early. What are your differential diagnoses for this patient? Okay, we are at 50% representation, so I'm going to bring this poll to a close. So Abasa, kindly carry us through the differential diagnosis that your team worked with for this patient.
Yes, we worked with these 4 differential diagnoses. One was meningitis in view of the fever, neck stiffness, and convulsions. We worked with a differential of complicated malaria in view of the fever, convulsions, vomiting, and passing of tea-colored urine. Sepsis was also in our line with septic shock, fever, in view of fever, tachypnea, tachycardia, and the reduced blood pressure as we saw, and also not leaving out acute kidney injury since this patient was passing tea-colored urine of reduced volume. We went ahead to do laboratory investigations as part of the recommendations from the pre-hospital team and also part of the management. Number one, we did a blood slide for malaria and there were no malaria parasites seen. MRDT was equally negative. However, we did a lumbar puncture to obtain the CSF for analysis, and from appearance, it was turbid. There were white blood cells and predominantly there were polymorphonuclear cells. The proteins were equally present, and we equally did a gram staining on this CSF, and it showed gram-positive diplococci, +++. We equally did culture and sensitivity. Unfortunately, we can't provide the results now. They are not yet ready. Other investigations, we did biochemistry. This report gives us a combined report of electrolytes of choice, renal functional tests, and some part of liver functions test. Starting with what we are seeing there with the line, it is potassium, which was elevated 6.3. Yeah, it's elevated. We equally had sodium elevated, creatinine, it was 1.7, higher from our normal range of 0.1 to 1.3. Urea, it is equally high by about 2-fold. ALT, it's high by 3-fold. AST, high by about 8-fold. Yeah, grossly, this showed us direction. Next slide, please. Yeah, we quite did a complete blood count, and it was grossly normal. Really, it was grossly normal with a normal HB hemoglobin, with a normal right blood cell count. The platelets were slightly low, and the percentage of neutrophils was high. So it showed a small rise in neutrophils, so neutrophilia and some thrombocytopenia, but it was a grossly normal CBC.
Okay, thank you, Abasa. So, Dr. Kenneth, we've this is the new update. Would like to know your thoughts on going forward for this patient.
Yeah, thanks. As following along, and as I had a list of differentials right from the beginning, and I go just checking them off. One of the things I thought about when I saw the T-colored urine, when I thought they were undergoing significant hemolysis, I also thought that they might be having rhabdomyolysis. And then the other thought was, of course, acute kidney injury. But then now from these new lab findings that we have, obviously, in the emergency unit, you may not immediately have immediate CSF results. There are some results you can get immediately, like cell counts and gram stains. But if you after the LP and you see that the LP is turbid, now you are certain that this is meningitis. But obviously, it's always good to keep it at the back of your mind that again, that yes, just because my patient has meningitis, that doesn't mean that's the only problem that's wrong with them. Obviously, now we've discovered, and this is a fairly common occurrence in our setting, that a lot of times patients who have fever, one of the things we quickly think about is malaria, and rightfully so. But then if you fixate on malaria, then what happens is you're giving this patient anti-malarials, they're not getting better, they seem to be getting worse. And if you've not thought about other potential differentials, then you miss out on the bigger picture. So it turns out that it's highly unlikely that this patient had malaria, and maybe if they did, then that had been taken care of by the anti-malarials that were given. Though I'm a bit when I look at the RDT, because I think that done RDT and that was negative as well, and that would be such a quick turnaround time for it to become negative. So obviously we've done we've seen turbid CSF, we've seen, thank God, we've seen gram-positive diplococci, because it would be quite an interesting story if it was gram-negative diplococci. So we have gram-positive diplococci, so we are thinking about, okay, what group of organisms is this? But we've given the meningitic dose of antibiotics. But two, the other thing is now this is a patient who has multiple organs that are failing. So obviously, one, we've determined that they came in with a reduced level of consciousness, and that means that their CNS is failing. We've noted that they had a reduced urine output. We've seen that they have an elevated urea and creatinine, and they have hyperkalemia, which means that their kidneys are failing as well. I see that on the liver function tests, the transaminases ALT and AST were elevated. So that means there's a degree of liver injury, though we do not know. We don't know whether the liver is actually failing, because we need to check the synthetic function of the liver. But if you think about well, the child had hypoglycemia, maybe there's a degree of liver dysfunction. So you have kidneys, you have the liver, you have the CNS, and now you're getting, and then you have the lungs, because this patient, even while at 10 liters of oxygen via mask, was still desaturating and quite tachypnic. So that means the lungs are failing as well. So a couple of organs are failing, and we are now fairly closer to what might be wrong with the patient. There was a primary bacterial meningitis, but now we have multiple organ dysfunction. And obviously, if we're going to turn around this patient's clinical situation, is that we have to address all these things together. So one is have a plan for how we deal with the renal injury, have a plan on how we support the respiratory system in the period that it's failed. Of course, source control, because now this is a patient who has sepsis. We've identified a source, so we must jump on source control, and then obviously then support the other things, the other systems that we looked at there that are failing. And that's why I said this was a very good thing that we're moving the kid to critical care for them to get mechanically ventilated. The CBC looked a bit bland, but this is what happens sometimes that yes, child has meningitis, but then the white cells have not moved anywhere. And the hemogram looked quite, I mean, the HB as well as the hematocrit looked bland. I didn't get a chance to, I think I missed the platelet count. So yeah, so those are my thoughts at this point in time. So yes, antibiotics for the meningitis, the plan for the acute kidney injury. Then of course, if we're managing the fever with this evidence of liver injury, then we have to think about other agents for use outside of paracetamol. And that makes it a bit tricky, but there are other substances that you might be able to use. Yeah, so those are my thoughts up to this point in time.
Okay, thank you so much, Dr. Kenneth. Over to you, Abasa. Just over the next 5 minutes, walk us through your working diagnosis, management, and disposition of this patient in 5 minutes, so we can have a little bit more time to discuss your patient. Thank you.
Thank you so much again, and our expert, thank you so much. So our working diagnosis became bacterial meningitis, hyperkalemia, acute kidney injury, and sepsis from what we've gathered, that is history and the lab investigations. Next slide, please. Yeah, and this was our management plan. The patient was intubated. However, the BP now reduced from our 94 systolic, it now came to 86, and our systolic also from 68 to 35. The pulse rate instead increased to 152. The SpO2 just increased by 1%. IV, we gave IV phenobarbital 180 milligrams. Our plan was to continue IV phenobarbital 180 milligrams 8 hourly, to give also IV ceftriaxone, a dosage to counteract the meningitis, 2 grams 12 hourly. To continue with IV paracetamol to reduce the fevers. And here maybe I may need to add to you that the fevers, by the time we checked on the patient, they had reduced to normal 37 degrees Celsius, up from 42 with the IV paracetamol. We equally gave IV soluble insulin 3.7 IUs with calcium gluconate. And now we were giving normal saline 1 liter. Maybe for our expert, this patient was 37 kilograms. It was 37 kilograms, and in our normal saline, we added 1 ml of norepinephrine in the 500 ml of normal saline as a constrictor, because you can see literally that the map of this patient was reducing. The progress of the patient, what followed and what. It's unfortunate that this patient continued deteriorating irrespective of the interventions that we did. And from the time they showed up at emergency to the time this patient passed on, it had taken around 8 to 10 hours. And may his soul rest in peace. So it's up to us to know what was the cause of the death. Was it because of the respiratory failure? Because this patient aspirated before he reached the hospital, the lungs were not picking up. Could it have been because of shock or any other thing? It is up to us to know.
Okay, thank you so much, Abasa, for this wonderful case. Now, we are going to welcome Dr. Kenneth to give us an overall expert opinion, focusing on the different aspects now that we've seen the case from pre-hospital right to the point of disposition. What are your thoughts? I noticed that there are a lot of questions on management of this patient. If you could move back in time and you're the one managing this patient, what you do have focused on? Yes, and re-emphasized. Over to you in the next 5 minutes. Thank you.
Thank you. This is quite a, a huge topic. I'll try and do it justice in 5 minutes. Okay, good. So one is obviously this is a patient who presented with fever and an altered level of consciousness. Now, when a patient presents like this to the emergency unit, sorry, there are a couple of things that you need to look out for. So anyone who comes with fever, immediately you need to assess for, you need to risk stratify them in the emergency department. And you need to find features that sort of suggest that this patient has sepsis. So some of them include altered mental status, if the patient is hypotensive, are they tachypnic, are they hypoxic, do they have poor perfusion, okay? And if they have fever and any of these features, then you should treat them as them having sepsis, even if you do not know the source of the sepsis, okay? Because then this allows you to sort of front load some of the interventions that have been known to have mortality benefits, or things like early antibiotics, IV fluids, and early vasopressor therapy were indicated. So obviously we, and then of course now you, as when you look at those initial features, then then you spend the next few minutes trying to do a rapid physiological assessment, which is what you do in the ABCDE assessment. And you're really looking out for red flags. So patients who have an altered level of consciousness, which our patient had, if they have a systolic blood pressure that is less than 100, or features of hypoperfusion, that is a red flag. If in their history there's a history of reduced urine output, that is a red flag, because you know then that there's renal hypoperfusion, and renal hypoperfusion is just an indicator of general hypoperfusion. Then if you're in a place where you can obtain a lactate, it would be nice to obtain a lactate. So through that workup, we discovered that our patient had a multitude of organs that were compromised. So all the way from the airway to their breathing that was compromised as well. And the breathing was bad, but not too bad. At least I do not think it is what led to the patient's demise 10 hours after admission. Maybe we just missed the part of, okay, when the patient was mechanically ventilated, how were their respiratory parameters? But like I had hinted on before, that if you're going to mechanically ventilate a patient because you switch, because when you're breathing spontaneously, that is negative pressure ventilation. So every time you take a breath, there is negative pressure in your chest, you facilitate return of blood to your heart, which in turn improves cardiac output. Now, if you're switched to positive pressure after you've been intubated, then that means that because of the increased pressure in the chest, then venous return to the heart is a bit compromised. That is not a problem when you have stable hemodynamics. But now when you have hemodynamics, like for this child who was hypoperfused, had low blood pressures, that's why we saw that after they were mechanically ventilated, then their blood pressure then continued to drop, and then we had to start them on an aerodrop. And this was the right thing to do. And sometimes you think, okay, fine, if I've given the initial fluid boluses and I treat it as sepsis, if I don't have the response that I expect to have, then I need to start vasopressor therapy early. And for a 37 kilogram child, of course, we all know the dosing. It's usually from about 0.01 to about 1 microgram per kilo per minute. And normally you titrate the dosing to the blood pressure. Usually we are aiming for a mean arterial pressure above 65. And so once you get there, then you know, okay, now this is the kind of pressure that is enough to maintain perfusion to the important organs. Now, of course, we'd given I think 37 kilograms, so 100 milligrams per kilo, so that this child would probably have required about, because if it's 100 mg per kilo or 37 kilograms, probably would have needed 3.7 grams of ceftriaxone. We'd given 2 grams So meningitic dose is 100 mg per kilo, and maybe that's the small change I would have made. We've spoken about the volume boluses to see if the shock was volume responsive. And after the volume boluses and you initiate vasopressors, then you need to keep the child on maintenance volume ongoing. And then, of course, there was the small issue of acute kidney injury with the hyperkalemia, and I think they've done very well in terms of shifting it with insulin. And of course, in a patient who's hypoglycemic, then you give them insulin together with dextrose. And then the other way that you can shift is that you can nebulize with salbutamol. And then if the patient, of course, is monitored, if they have cardiac monitoring and you see any ECG changes that are suggestive of hyperkalemia, then it's also a fairly reasonable thing to be able to give them calcium gluconate just to stabilize the cardiomyocytes. And then, of course, so we have antibiotics, we have respiratory support. We are giving volume to try and see if we improve perfusion to the kidneys, whether this will improve the renal dysfunction. And then we've provided treatment for the hypokalemia. But then again, remember that this is a patient who was significantly sick from the get-go. And sometimes even with the best intentions and the best interventions, you are fighting a losing battle. But I think in terms of approach, that is how I would have approached it. First, I think, is this sepsis? And if it is sepsis, then it allows me to quickly go through antibiotic therapy, volume therapy, early vasopressor therapy, and then monitoring response to treatment. And if it is not sepsis, but this child looked like they actually had sepsis with multi-organ dysfunction, then of course you go through the things we went through, and then obviously we know now that the source was probably the CNS, and we have given the broad spectrum antibiotics that we should give. Normally, if it is bacterial meningitis, there is actually room to give some steroids because they have a mortality benefit. And then of course, and I think the transfer to the critical care unit was one of the big pillars of being able to take care of this particular patient. And then, of course, catheterize them and monitor urine output. Yeah, but it is very, very important that check for features of sepsis. If there are no features of sepsis, then look for red flags. So in patients who have fever, what are the red flags? Some of them include extremes of age, patients who are immunocompromised for one reason or another, patients who have indwelling medical devices, patients who have malignancy or are on treatment for malignancy. These are the patients that you would treat as having a red flag if they presented to the emergency unit with fever. Yeah, thank you.
Thank you, Dr. Bagonza. You've done a good expose of management in the emergency department. To the team, usually we manage a patient who is undifferentiated, so we deal with a lot of things. Abasa, I don't know how you're going to do it, but you have 3 minutes to tell us your take-home message. Thank you.
Thank you so much, Dr. Ann, and our expert, Dr. Bagonza. I think I don't have the capacity to dilute any of what Dr. said. Specifically, it is that think sepsis first, and using the tools which are usually available to us, as someone suggested in the chat, the use of news, the Q-SOFA, which is bedside, identifying the source and the risk factors. It is so much important. As we've seen, the management of this sepsis will stay right away from its pathophysiology, and that's it. So this is examples of tools we can use in identifying sepsis. As we can see, it progresses very fast, and any day will increase the mortality to a very big percentage. I read it was about 10% any day in 1 hour. So large, and in a nutshell, I think screening sepsis, thinking sepsis, as our expert has said, when you see fever, when you see tachypnea and something that is not responding to antimalarials, it's right to attack as you're attacking sepsis. Next slide, please. Yeah, the management, I think our expert did a very great job on it. Most of the things were talked about: the oxygen, the start of the antibiotics, timely giving the right dosages, that is 100 milligrams in meningitic cases. Then the fluids, the boluses, as he said, the the giving of crystalloids, as he warned us from the start. The other side, when you give 5% dextrose, that this glucose is going to go away, and then you just remain with water in the extracellular compartment of the body. The use of vasopressors when the mean arterial pressure goes 65. By and large, this is it. Let's think sepsis first. Next slide, please. So these are some of the complications. The septic shock can come following sepsis, acute respiratory syndrome, the AKI, and other organ failures we saw, and the meningitis as we see in this case. Next slide. These are our references: Surviving Sepsis Campaign Guidelines. However, they released new guidelines for sepsis early this week, the 2026. I had used these ones, and equally got some information from UpToDate, Medscape, and our usual textbooks, Davidson's Principles and Practices of Medicine, 24th edition. Otherwise, thank you so much, and thank you to my mentor who helped me in doing this, Associate Consultant, Dr. Dan Oriba. And to you all, I think we can go on and read sepsis, and we convert this knowledge we've gathered here into practice. That's it from me. Thank you so much, our moderator. We are out of time. Let me stop here. Thank you so much, everyone, for attending.
So thank you so much, Abasa, for compiling this case. I would love to, we're in the top of our hour, but I would love to ask Dr. Oriba, who was very key in preparation of this case, in a minute, to give us his thoughts on care, on give us his thoughts as someone who was involved in care of this patient. Dr. Oriba, you're welcome.
Thank you very much. Abasa and the team, excellent work done. We are still puzzled about the death of this child because we have really had very good outcomes of patients with meningitis. This particular case reminds me of one of a mother who has been reporting frequent pneumonia attacks, and she delivered. Then she got very bad pneumonia, which required also mechanical ventilation, and she also got meningitis until we did C3, C5, and C2B, and we found she had hypocomplementemias. So these patients actually are there with us, and that's why I've put in the chat that, a patient who is not probably responding, going very fast, you don't have a very good response. You can see the CBC is not showing any very good response. Is this bacteria really evading the immune system? And so if it's evading the immune system, is the complement system really working? And so the time frame was so rapid, everything was rapid, and we couldn't think of it because I think within that same week, we had a young girl who is 14 years old, and she has been on mechanical ventilation for 7 days, and she survived. We were all puzzled why this did not survive. So sepsis is very bad. And, I always tell people that don't forget, the guidelines could be changing, but don't forget the first things that you do in the first hour, the 6 bundle, 1 hour. It's very important. Timely administration of antibiotics, source control, taking your blood samples, making sure that your patient is well perfused with a very good map, making sure that you also have a lactate if you're able to do it, and oxygenation should be, available for these patients. So I think the team did a good work, but, the outcome was not very pleasing, and we are still puzzled why this occurred, but because we also didn't do post-mortem. But the only thing that I want to advise everyone on the group is that sepsis will still, it's still going to continue to be the leading cause of death. We need to update ourselves with the sepsis guidelines. Don't just stop at QSOFA. Make sure that you also do a new score too for your patients, so that it gives you a better understanding of all the vitals that this patient is having. Otherwise, I thank you so much for having me on this forum, and thank you, Abasa, for bringing out a very good case. Thank you.
Thank you, Dr. Oriba. Thank you, Abasa. Thank you, Godwin. Thank you, Dr. Bagonza. Thank you so much for giving us your time. And to everyone that has stayed till this moment, we thank you. Lastly, I would love to thank the team that is behind the screen, always preparing these sessions to make sure that we have them running. Yes, there is a post-session poll. Sorry, please don't go off the poll. We did have our first question, which was from the primary survey, what are the imminent emergencies for this patient? Yes, and the correct answer was we had a threatened airway, we had a respiratory fatigue, we had distributive shock, we had convulsions and hyperpyrexia. The next question was, what are the emergent ED interventions for this patient? And our answer, most of us got this right. It was getting an advanced airway, mechanical ventilation, crystalloids, and an anticonvulsant. Then the third question was the differentials, and largely most of us got this right equally. Was cerebral malaria, meningitis, sepsis, and acute kidney injury. Thank you to the CPC team that always prepares this and make sure that we are able to learn. A kind reminder, these sessions occur once every month. We do have a list of topics that we'd love to share with everyone. So Katushabe Erica is our coordinator. She reaches out to the different universities. If you have an interesting case, please let's learn together. Reach out to Erica so that we can share and get platform to learn from you and from the patients you are seeing that side. From the CPC team to you, thank you so much for joining. Till next time, bye.